All right, in the interest of time, I say we go ahead and get started, if that's okay with you, Dr. Johnson. Thank you all for being with us tonight on this wonderful Tuesday night. The weather is being a little bit warmer for us in February. So, get my slides to go. So tonight's agenda, we have two things. We have a presentation from Saranya, and we're also going to discuss the FIT scholarship. So we thought we'd go ahead and open it up with the FIT scholarship. So just a few things. So we're going to open our Jack Cronowith Award scholarship submissions beginning tomorrow, so Wednesday, February 21st. But we are going to go ahead and show you the links tonight, but they won't go live until tomorrow. So just want to share that with you. So the deadline for submitting these will be March 13th. That's also a Wednesday. And then the committee will be reviewing and ranking those award submissions. They'll have approximately a month from March 14th through April 15th. And just as soon as we get those results, there'll be five that will be awarded. There's always a maximum of five that are awarded each year. Once we have those results, we will let you know probably April 16th, 17th, or 18th, just as soon as we know, so you can make your arrangements to come to VQI at VAM to accept your award, which will be held in June 2024, which is actually the June 18th and 19th. That's a Tuesday and Wednesday. So those are the dates for you. And there are two required components for you to apply for the FIT Jack Cronowith Scholarship. One is actually your FIT mentor endorsement application. So this is your mentor that's going to fill out a separate application. And again, I'm just going to go through it real quick with you. And just basically supporting and how they feel, how you and your project are going, and they're endorsing you for applying for this scholarship. And then there's also your portion, and I've just labeled it as the FIT trainee application. And one more thing is it's not required, but we do highly encourage you to submit any supporting documentation of your project to myself. And then what I do is I blind that and attach that to both your FIT mentor endorsement application and your FIT application. And then that blinded packet together, that completed blinded packet together, goes to the committee. So everything is sent directly to me. I grab it, I blind it, and then the committee reviews each application separately. So again, all of this will be emailed, like the FIT mentor application will be emailed to the mentors, and then the FIT trainee application, and again, all of this is directed toward the Jack Cronowith Scholarship, will be emailed directly toward the FIT trainees. But here's the link and the QR code for the FIT mentor endorsement. Give that a minute so people can take a picture of that. And again, I will also put it live tomorrow on the website. So when you go to vqi.org, you can hit quality improvement and then select the FIT program. I also have a hyperlink in just a moment. I just want to give everybody just a second to grab this. And also the FIT trainee application portion. Here's your link and your QR code. And it's really it's not as in depth as your original application, and I can show you live if everybody would like for me to do that. Give everybody just a minute. And again, like I said, I'll be emailing all of this directly to each individual, and then here's our website right there. So again, it's www.vqi.org. /quality improvement /quality fellowship and training FIT program. So what I'll do is I'm going to stop sharing for just a moment, and then I'm going to, sorry, I have to share again. I'm just going to hit share real quick. Well, get out of this. Sorry about that. Here we go. See if I can share it this way. go. So the first one is the FIT application. Let's rearrange everybody's faces over here. So whenever you open it up, you will see this, your Jack Cronowitz Scholarship application. You're going to have your FIT trainee name, email, PGY, your center, and your FIT mentor. Again, when you see the asterisk, this is required. You're going to select whether your trainee project is either quality or research, because you will be graded whether it's quality or research. There's two buckets. So, you're graded. We have a grade for specific to quality, and then a grade scoring for research. And then if it's part of a RAC project, we do ask that you identify your proposal number and the project title. Kind of helps us. And then overall, we're asking you just to select the option that best describes how complete you feel your project will be as of June 2024. And again, this is just your best estimate. And there's no wrong answer here whatsoever. And then your personal statement in 250 words or less. Summarize your FIT trainee project and let us know the purpose, the approach, findings, and again, feel free to email me with any supporting documentation. You can also share, how you have been sharing your FIT project. It could have been a presentation, it could have been a charter, publication. You're going to present it at BQI at VAM. Anything, within 250 words or less. And again, any supporting documentation. If you want to attach like a PowerPoint or your presentation, what you're presenting, coming up or in the past, make sure you email that to me. Then your area of activity. What truly best describes your FIT project? And then what registry was utilized for your project? And then the last thing, again, this is just a reminder. And also it kind of helps me kind of keep track of if I should expect documentation or not. If you have completed, meaning you are going to go ahead and email me some supporting documentation, or if you don't have any. And again, there's no right or wrong answer here. We just want to give you the opportunity. And again, that just helps me with my Excel spreadsheets. So that's it for the FIT trainee Jack Cronowitz scholarship application. And I'm going to flip over to the mentor, what's expected from the mentor. And again, this is basically the FIT mentor endorsement for the Jack Cronowitz scholarship application. And I want to, kind of really hone in that you have as a mentor, you've discussed this with the FIT trainee and you are in agreement that he or she should be recommended for this scholarship. So again, it's just going to be the mentor name along with their FIT trainee name. And again, you're going to select the best option. Is it quality or a research project? And then just in your words, 250 words or less, if you could tell us about the project and why your FIT trainee, should be endorsed and awarded the Jack Cronowitz Scholarship. And we do ask that you comment on whether or not the FIT trainee played a primary or secondary role within the project. Again, no right or wrong answers. We just like to have your perspective as a mentor. And Adam, would you mind just kind of sharing, or Gary, about the Jack Cronowitz Scholarship?
Sure. So yeah, this scholarship is we have just our first class was selected last year, and this is a scholarship that really is to supplement. Jack Cronowitz is for maybe any of the new FIT trainees, is someone who's very known within the quality world and within vascular surgery, and was really one of the founding kind of thought leaders behind BQI. And getting it established, and a lot of the analytics and how the data is managed. So yeah, this is really a way for us to take these projects and support them twofold. One is by there's a monetary component that might help people to visit meetings or to collaborate or fund their project, or there's which is a prize, which is it's kind of not earmarked really for anything. And then the second is kind of in-kind resources in that where we really want to work to support this with however it can align with what the BQI already has in resources around just expertise with a certain registry, expertise with a certain QI methodology, expertise with any resources that have already been developed by other programs, or connections with the analytics group that the BQ already has. Our goal is to kind of tailor that connection to one, support the project with the kind of in-kind resource BQI has, but then also give that scholarship awardee further exposure to kind of like peeling open BQI and getting in and really understanding what happens under the hood, and kind of networking and kind of being able to see that side of it. So it's that's really only available to kind of a select few, and we hope you all apply to it so that we can support you in this kind of souped up way. Hopefully that answers that. And then if Betsy
Yeah.
or Gary has anything to add.
And also, with the 5 scholars from last year, the awardees, they have been so instrumental. We've been able to, the PSO have been able to mentor them, and they have played such a wonderful and important role. They're on our RAC committees, they're on our various committees like our PVI committee. They're involved in assisting with our quality and rapid fire poster abstract review committees for BQI at BAM. They have been working with our analytical PSO group. I mean, they have just it's been wonderful to see them grow from, they're still the trainees, now they're scholars, and, while working on their projects hand in hand. So I cannot say enough about this scholarship and just the affordability that we as a PSO can offer, and with our, mentor and just different opportunities that may can only have just at a center. It's just an extra opportunity to see different views of what we at VQI, so that's my view from being from VQI and seeing where the scholarship has truly gone, and that's just with the first group. So I think there's going to be more and more that we find and are able to offer. Gary, did you have any thoughts, or Jim?
No, I think you and Adam both provided a lot of useful information there. I view this scholarship opportunity as a method for highlighting a career path, and I think being able to work within the infrastructure of the VQI, and particularly to gain more access to the mechanics of the PSO and how it runs VQI, as you mentioned, is a very good segue into a professional career. So I highly encourage everyone to give strong consideration for this. We do have a limit of 5. We think that's appropriate, but the 5 who were then selected, there are multiple opportunities that are open up for them. So I'd encourage everyone to apply.
Are there any questions regarding what we've gone over or said, or anything regarding the scholarship at all?
I also do want to clarify one thing, is that I think one tough things about QI is really understanding what the end is and what a complete project is. What we're really trying to get here is we're really trying to reward and award a person, and what we want to understand is your contribution to your project. And so I think a big thing is, in these applications, we want to see highlighted what you've done, and it may be that you haven't dropped the infection rate or reduced the length of stay. There's a lot of things that go into whether that project is successful, but what we're funding is you as a person who's kind of participated in this project. what you've done, what you've learned, how you've grown, how you've contributed. And so I think really highlighting that, because you might be like, well, gosh, we're just still kind of plowing through this project, and we're not done. And so there's no way we can, apply and kind of go for this project. But what we're looking for is what is kind of what your experience has been, and kind of that work, even if it's not quite quote unquote done.
Awesome. Okay. So I'm going to stop sharing one more time, and I'm going to go ahead and turn it over to Saranya. She's going to present. Would you like for me to pull up your slides, or do you want to try and pull up your slides? Oh, sorry, you're on mute. Ah!
There we go. Let me see if I can get
Okay.
this then. Okay.
If not, I'm ready with them too.
Okay. We'll just see if I can just share my screen. Okay. Let me do it. Wonderful. Cool. Okay. Can you see my presentation?
Yes, we sure can.
Okay, wonderful. Let me just see if I can get this to be a big screen. There we go. Maybe. I'm trying to get this to be a big screen. There we go. I'm just gonna do this. There.
Yes.
Can you still see it? Okay.
Perfect.
Wonderful. Hi everybody. I'm Saranya. I'm one of the current research residents at MUSC. So I've been doing this program kind of during my third year of research. I am really interested in outcomes research, so I've wanted to focus on one of my two areas that I do a lot of research in, which is PAD and carotids. But this was kind of my first foray into like really understanding quality improvement measures. And Dr. Brothers has been a great mentor. He's had a lot of experience in that space. So a little bit of background. Basically, where this project came from was that we did our quarterly department VQI review, and we found out that at MUSC, we were about 4 days or 2 days behind our national and Carolinas average for length of stay. Kind of why we thought length of stay might be something that's interesting to look at. Costs obviously are pretty widely vary from 7,000 to 36,000 in different regions, often because of the varying lengths of stay. And then region and center of treatment obviously account for about 18% of that variation. Dr. Ross did a very similar kind of look at VQI stuff in 2017. And I found a couple of factors, but there hasn't been a ton of research that's identified exactly what measures could affect those factors and whether or not implementing those factors could change either hospital costs or length of stay. So we kind of took on a pretty big project that we split up into a couple of different parts. And the parts that I've gotten done so far right now are, number one, looking at the factors on an institutional level, looking at our own MUSC VQI data that's associated with longer postoperative length of stay. And that's IRB approved. And then we also implemented an institutional level quality improvement measure targeted at MUSC specific factors prolonging length of stay, which we got quality certified on as well. And then I applied for a RAC proposal in December, looking at what factors contribute to extended length of stay on a national level, which I had a chance to look at that data as well. So looking at the factors on an institutional level, we looked at our MUSC data from 2012 to 2022. We looked specifically at our inpatient CEA. We excluded any patients, obviously, that were transferred to another service or were having an additional procedure like a staged CABG, as well as those who had CEAs for non-traditional indications. And we ended up looking at about 546 patients at our own institution over those 10 years. And then I applied Cox regression analysis, looking at time to discharge and which factors either prolonged or shortened that time to discharge. So some of the factors that we found are over on the right. The big ones that we looked at were uncontrolled hypertension in the pre-op period, as well as an urgent and emergent setting, and then also post-operative, any complication as well as hypertension. And then obviously a really, really big factor at most institutions is the discharge to rehab or SNF versus going home. So looking at those factors, we wanted to implement an institutional level quality improvement measure to see whether or not we can target those MUSC specific factors prolonging length of stay. So we thought again, took another very close look at which factors we thought would actually be modifiable. Specifically, we thought the incidence of uncontrolled hypertension, both pre-op and post-op, would be a place to address. Also, early identification of social factors with potential to prolong length of stay, such as whether or not they were admitted when they were evaluated, their risk factors, their ASA score, Rankin scores, and then whether or not this was performed in an urgent and emergent setting or if they had discharge needs. And then also third, looking at the early identification and treatment of postoperative complications to try and reduce length of stay. And we kind of asked ourselves, what do we think we could accomplish with changes in institutional practices? And that's not necessarily a question that I think has been asked of the literature quite yet. But we thought that we could almost use length of stay. In this case, we're using postoperative length of stay because obviously length of stay tends to vary a lot more than postoperative length of stay as a surrogate outcome. And then also whether or not it could reduce healthcare costs and optimize use of hospital resources. So the first quality improvement measure that we started working on last year was implementing the standardized documentation summarizing care prior to transfer to vascular and general plans for OR post-op. So essentially at MUSC, the paradigm that we use is that our medicine service or our stroke neurology service will typically be the first ones to evaluate a patient in the emergency department who comes in with concern for stroke. So we will typically be consulted by that service who is managing them initially, and then they'll be transferred to our service if treatment is indicated. Otherwise, they'll often be discharged and then see us in clinic if it's not indicated. So in order to address this, we actually met with some of the other departments. We're part of a larger stroke center. And so we collaborated with the director of the stroke center, who's a neurologist, Dr. Homestead, as well as some of the neurosurgery attendings who do perform carotid endarterectomies at our other location. So what we thought that a more standardized note would address was, number one, it could help improve the incidence of uncontrolled hypertension by essentially making sure that people are aware that there is a history of hypertension, that they do have medications that they've started, and that those medications need to be continued or their hypertension needs to be controlled before the OR. It also allows for early identification of social factors, as well as the early identification of complications. And we've started implementing use of this note in place of a transfer summary in January 2024. So these are just more examples of the note that we have implemented. Essentially, it's going to be a joint collaboration between two services on creating this note. The stroke neurology service or the medicine service will fill out essentially all of their pre-operative care, and we'll fill in what's needed in their post-operative care and what we anticipate might be an issue in their post-operative care as well. And we hope that this note will essentially be a centralized note that can be referred to by nursing and by anesthesia or any other services that might be involved in the patient's care. Our second quality improvement measure that we've introduced around the same time was we took a look at the order sets that we were using for postoperative CEAs, and essentially those measures had not been revised in over 10 years. The old guidelines that they had used to link to were all obsolete, and a lot of the other links for nursing to be able to follow how to do like a baseline neuro exam and what kind of things we look for were all not available anymore. So essentially, we not only worked on getting a brand new vascular surgery carotid pre-op checklist, order set created, but we also worked on revising the 2 TCAR and CEA postoperative order sets. So the new preoperative order set, we were hoping will improve our incidence of uncontrolled hypertension. We now have a section that focuses on PRNs for blood pressure issues, as well as kind of has that standard set of orders to get the patient ready for the OR, and very strict blood pressure goals. We also plan to now consult anesthesia prior to going to the OR for A-line placement so that we have invasive monitoring earlier in the process. And then also consulting our physical therapy and occupational therapy colleagues earlier, as well as anesthesia, to be able to address any modifiable risk factors before the OR. And this is our revised order set. This is just an example of some of the things that were included in that one. Again, we now have that link to the actual SVS guidelines that was not available before. And we also have a more time of care based order set, essentially. So there's a order set that focuses on the PACU care, so looking at nursing monitoring and nursing orders, as well as blood pressure medications that we often use in PACU. And then a separate part of it that looks at the floor and what that care might look like. So again, we were hoping to address both the incidence of uncontrolled hypertension and the early identification and treatment of postoperative complications through monitoring. And then we had our idea to kind of compare what factors we had found at MUSC and see if they were similar to the factors that nationally we see. So I did submit for a RAC proposal that was approved in December. And essentially similar, we did looked at patients between the years of 2012 and 2022, specifically inpatient CA, had this very similar exclusion criteria, had about 10,000 patients, and performed Cox regression analysis to determine whether or not time to discharge significantly differed with these factors. Looking at obviously the national data, it's a little bit easier with that many patients to get more statistically significant factors. Some of the ones I thought were kind of interesting was that a history of a contralateral stenosis of greater than 70% was a risk factor for longer length of stay, as well as a higher creatinine and use of aspirin, use of any beta blocker. However, use of a chronic beta blocker, so greater than 30 days, was more protective, as well as aspirin use preoperatively, as well as a higher hemoglobin. And this also looked at the procedure details and some of the long-term complications as well. So again, use of a drain, use of general anesthesia, or a concurrent revascularization procedure were all things that could increase length of stay. Again, the big things that we looked at were obviously the ones that were shared between the two, which were inpatient evaluation, or whether or not the patient was inpatient when they were scheduled for surgery. If they were non-ambulatory, if they had a history of hypertension preoperatively, their preoperative risks such as ASA class, or whether or not they were in an emergent setting. Use of drain, which is actually something that Dr. Ross had found when she did her initial analysis in 2017. Postoperative hypertension, any postoperative complication, and then obviously discharge to a rehab or a SNF. So why does that matter? I thought it would be interesting because I did have the long-term follow-up data to just see whether or not postoperative length of stay actually did correlate with any adverse long-term outcomes. And having a postoperative length of stay greater than 2 days versus less than 2 days actually had an increase 1 year postoperative all-cause mortality. And that protective effect of greater than this many days post-op versus this many days, less than this many days post-op, was seen up to 30 days. Similarly, with a postoperative length of stay of less than 3 days, you had increased postoperative ipsilateral stroke rates, reduced 1-year reoperative CEA rates, and then in postoperative length of stay less than 6 days, you had a reduced incidence of persistent cranial nerve deficit. So looking at all of those, basically we've kind of completed our data collection phase of our project. We're now looking to kind of see how we could integrate that into something that's more usable. Our next step that we're looking at is actually combining all the factors that we found that were shared between our institution and national data, and developing a model that has, beta weights based on those individual factors to see whether or not we can create a risk factor scoring system looking specifically at preoperative risks to kind of classify people as either high risk or low risk. And then essentially we're hoping to take a look at the end of this following year. It'll be January 2025 when we are full year out of our quality improvement outcomes, and see whether or not there was any effect on postoperative length of stay. And if we did apply our models to our patients, if certain people were high risk versus low risk, whether or not it affected them differently. And that is it for my presentation. I'll take any questions.
Fantastic presentation. Yeah, we'll open it up to the group to see if anyone has any specific questions. If no one else has any, I've got one. So did you look at what your kind of patient cohort looks like compared to what the national cohort looks like, and kind of your rate of symptomatic and inpatient and things like that, and just to get an idea of kind of what you're starting with as kind of the patients that you're working with?
Yeah, so there was a couple of big demographic differences that I think definitely affects South Carolina individually, especially MUSC. We have a pretty large transplant program as well as a heart transplant program. So we tend to get a lot more ESRD patients than nationally, as well as CHF patients who are referred to us for CEA either preoperatively before they undergo transplant or as part of their workup. So we did have a higher incidence of both of those, I believe. And then we do also have a pretty significantly larger African-American population, especially those with vascular disease, as well as more women. But I think those were the only factors that I found that were different between those two populations.
Great. Definitely a complex patient cohort. Dr. Lemon, I see that your hand is up. Sorry if I missed that earlier.
Yeah, that's fine. Nice presentation. A couple of questions, and maybe a suggestion as well. The question is, the report that you get from VQI, which you demonstrated was MUSC was approximately 4 days for that, doesn't differentiate from a symptomatic patient, whether they stay in the house first and go home and come back and be readmitted, or the patient actually stays for the entire procedure during the incident hospitalization. The post-op length of stay is what is targeted in that report. So my question to you is, what percent of your patients who come through the emergency room seen by a stroke neurologist, you are then consulted for that patient, what percent of those actually go home, get rescheduled within a reasonable period of time, and versus which ones are those that stay for their procedure during their incident hospitalization? I think there's a big difference between post-op length of stay in those two groups. The one who goes home and gets readmitted later on, you have the opportunity of arranging for disposition by the time that you've done the operation or even before.
Mhm.
The ones who stay in the hospital makes it extremely difficult to start that disposition process immediately. And my question is, how do you handle that?
Yeah, that's actually a great question. It's something that Dr. Brothers also brought up as well, and that we discussed as we were trying to kind of address our quality improvement measures as well, and whether or not it would be feasible for us to do that, or have that be involved, or us to take that into account. Actually at MUSC, this is part of our interdisciplinary discussions as well. If a patient is seen by the stroke neurology service or the medicine service as part of a stroke workup, if they do have symptomatic carotid disease that is meeting indication for treatment, we actually have had a significant pushback from our neurology colleagues to send them home. So almost all of them will undergo a CEA or stent during their hospitalization for that initial stroke, unless they are unstable or unable to undergo that procedure. Right now, looking at our own data, really the only people that end up going home are the asymptomatic patients.
Which leads to a challenging group of patients who you've lost some control on in terms of their dynamics of getting out of the hospital. By the time that the medicine folk or the neurologist consults you, at the time of that consultation, the disposition process should be initiated, regardless of when you've got a chance to do the operation, depending on how close they are to get developed, because that delays the discharge process significantly. In terms of, particularly if they don't go home. And if they go to a SNF or other places, then there's no way that you can keep that less than 2 days. So I would encourage you to look at that, and maybe change some of your process orders for that. That as soon as vascular surgery is consulted, there is a disposition process put out about arranging for home for placement, because when you see the patient, whether they're going home, where they're going to rehab center. Their stroke or their TIA is either passed or they've plateaued. So you can understand where they need to go most of the time. And that will reduce that length of stay significantly from that. My other comment is that hypotension, hypertension is in the eye of the beholder. And the threshold of treating those are also individualistic. So you may want to look significantly at that. We do know, based on VQI data, that any patient who is treated with either one of those parameters, hypotension or hypertension, has a higher 1-year stroke and death rate. That's been shown. The same process has not been completed in CEA, but has in TCAR. And so what I would encourage you is to look at your definition of hypo and hypertension, and obviously try to work away from intravenous medications, if at all possible, from that, because that is where you see the variation, and that is where you see that. So keeping an in-house patient on their normal antihypertensive medications preoperatively, in fact, sometimes reducing their preoperative medications to keep their blood pressure up, because you want to encourage perfusion of that stroke penumbra. So doing those things will help, but you have to make sure that you have your appropriate threshold for treatment. And so that will hopefully reduce your stay as well, in terms of avoiding prolonged ICU stay whatsoever. And one thing I didn't notice in your analysis was Foley catheter placement. And maybe you want to look into that as well. The less fillers you can do, the better for that, because that definitely will keep someone my age with a Foley catheter in a hospital one more day, or have a urology consult that can't see him until the next day, to be treated for that.
No, absolutely. I mean, that makes a lot of sense too. And we were actually wondering too if the drain was a similar situation where, people just felt like they wanted to keep the drain in for another day before they left, and that's why they took longer for them to get out. But those are some good points. I definitely need to take a look at what our thresholds have been used for in terms of hypertension in our own practice, because that could definitely be an area to improve on.
Do all your surgeons use drains?
No, it's very surgeon dependent. So I think probably I would say maybe 50-50 on the surgeons that currently do CEAs at our practice.
Well, since you've done your RAC proposal and you can look at that now, you can also look at the intersurgeon variability on length of stay and use of drains. It'll be interesting what you find.
Okay, definitely. I appreciate the feedback. Thank you.
Hi, Saranya.
Yeah.
I just wanted to give some comments as well. It's a great presentation and it's great work. I sent you in the chat box already. We did publish in 2019 about the impact of rural residents versus urban on length of stay after CEA using the national VQI data set. So I sent you that. The reason why I did is because we did a pretty intense lit review for it. So there's all kinds of info. What I was also just thinking for your project that would be a really cool additive to it, because part of what we kind of surmised was the patients, their socioeconomic status, some of these social determinants of health were really more of the issue. Why would they not have their blood pressure controlled coming in? Why would they have a harder time getting somewhere on discharge? These were things that, you don't look at a lot. I do think that the VQI is cross-indexed with the distressed communities index. Correct me if I'm wrong, but I would add those as a factor for what you're going to look at.
Okay. Yeah, no, that's a great, thank you for sending me that resource. I'll definitely have to take a look at it. It'd be definitely helpful for me to come up with some more factors that I might be able to address.
But you may have to add it to your request, but it's already made as a data set having the DCI attached to it.
Yeah.
So I think that'd be very helpful.
Okay, wonderful.
And I think two kind of QI tools that might help you also identify these factors and how to kind of put together these bundles. One is a fishbone. I think developing a fishbone where on kind of one side you've got kind of delayed discharge, and then on the different, create the different ribs, and being one is patient factors, one is hospital factors, one is service, surgeon factors and things like that, and put all those things and organize all those things, and then I'll help you just kind of put it out as the map of how all of these things interrelate to each other. Another one is a Pareto chart, and so going through those patients, not those patients who left on day one, but basically those patients that left on that day 3 and day 4, who are the ones that are kind of pushing or plus, basically any of the patients who had a length of stay greater than 3 days, go through and you don't have to pull out everything from their chart, but just read their discharge summary and be like, why were they delayed? And really tally up, say, okay, it was discharge to rehab, it was urinary retention, it was hypertension, and just put it into that bucket and create a Pareto chart for all the patients who had that delayed discharge and where they fell into those buckets. And I think that'll help you target in so that you really are looking at the high risk group, but the high risk group that's actually staying at your institution. Because while you'll create a national risk score, that national risk score might be for patients that don't necessarily look like yours and stuff like that. So I think those are two QI tools that might help you to really hone in and identify what your institution might be those components, adding to that increased length of stay.
Oh, that's a great idea. I definitely feel like I would learn a lot in terms of what measures might be more effective or are going to be the most impactful from that as well.
And they make great figures in your pub, so.
That's true too. Sharing.
All right, Dr. Brothers, do you have any comments or anything else to add for the project? I think
Sure,
did a
and
fantastic job.
hopefully you can hear me. Those comments are all very good. Actually, things we've looked at. We do not routinely place Foleys in our patients. We do without, so that's something that we had found quite a while ago. Most of the problems, and actually the rehab process typically is initiated early on, but the problem is that trying to get placement is a challenge. And so trying to get people placed even when they have the head start on neurology service becomes more of an issue. We have tried very hard to convince our neurology colleagues that it would be okay for the patient to go home first, but partly because we're such a rural state, they and many of our patients travel such a long distance, they're very uncomfortable with them being able to get back in to see us, and many of them are unfunded also, and it becomes a lot harder that you can the patient can get it done, get it approved to be done since they're already in the hospital, but once you send them home, then there are other kinds of things that come up. So those are definitely some of the challenges that we come up with. Saranya didn't mention, but we've actually gone through on a case-by-case basis for about 3 or 4 months worth of data in our regular VQI session that we have for the whole group, the residents and the faculty. And there are multiple things involved. Part of the problem too uh, is that sometimes what happens for a special extended length of stay is a patient with both coronary and carotid disease. We have a new set of cardiac surgeons. In the earlier days, we would just do them combined. Now they want to have their endarterectomy or their stenting done preoperatively, keep the patient in the hospital, and then they go ahead and get their CABG done. So that kind of messes up our numbers a little bit too. But Saranya's done an amazing job working and getting the neurologists and the neurosurgeons who do a smattering of the carotids in our group involved to kind of come up with with a plan and coming up with the sort of combined note to try to make sure everything is there, both to help the people capture the information, for VQI, but also to try to organize it so it's all there. And we are hopefully making some progress in terms of, again, especially with the hypertension, making sure people get their medicines ahead of time. Interesting, the idea of trying to just be a little bit more liberal in terms of what we allow. And that's going to be a tough discussion, I think, with some of my other colleagues in terms of getting everybody on board with that. But all in all, very, very good suggestions. And again, I'd like to congratulate Saranya that she's really picked this up and taken it and is trying to make the whole thing happen. And we'll see what effect this has when we get the follow-up data.
Fantastic. Yeah, congratulations on a fantastic project, and we can't wait to hear how things unfold.
Thanks for letting me share. I appreciate it.
Okay. Well, unless anyone has anything else to add or any questions about, and we look forward to seeing your application for the JC scholarship in a few weeks. So Any questions about any of that? Let us know. Otherwise, we'll set you guys free.
Thank you all so much.
Thank you.
Great presentation.
Thank you.